Felicia the Frog and Ian again with our patient assessments for cardiovascular and respiratory emergencies. First, we are going to go through our scene size up by making sure the scene is safe and we have appropriate BSI. These are important for the safety of ourselves as providers, our partners, and bystanders. If the scene is unsafe, we will not enter, and we must remember everyone has AIDS. Gloves and masks are especially important right now. Due to this being a medical emergency instead of a trauma situation, we will proceed with a nature of illness. Originally, we were responding to an assisted living facility for a 73-year-old male who is having trouble breathing. However, when we went to confirm it was only this patient, another patient was found having chest pain. While this was a new development during our response time, we are sometimes given misinformation. Therefore, we will have to call for additional resources as just my partner and I will not be able to adequately care for or transport both patients. After the other ambulance arrives, they would assess one patient while my team assesses the other. Also, due to both patients suffering from medical emergencies, the stabilization of their spines would not be required. Next, we will work through the primary assessment of both emergencies. This would include your GMC and ABCs. At first glance, our respiratory patient looks to be an elderly African American male in a high level of distress as wheezing can be heard and he is sitting in a tripod position. An ashtray is sitting next to his chair on a table. The cardiac patient looks to be a middle-aged Caucasian male around 55 years old who seems to be a high motor Down syndrome. As heart defects can be a complication, this patient has a history of angina during strenuous exercise. Today, however, it is not going away after resting. He is experiencing crushing chest pain and is clutching his chest. Both patients are responsive to auditory stimulus, but not visual, as one is looking down and the other is wincing. They are conscious though and responding with head motions. Moving on to the chief complaints, one is having difficulty breathing and the other throbbing chest pain. During our ABC assessment, airway is our first concern, so we must check their patency. Both patients have no upper airway blockage. If the respiratory patient had an upper airway obstruction, stridor would be heard. Secondly, breathing, so the rate and depth of ventilation would be monitored. To get proper diffusion, one must produce both time and space in ventilation. Auscultating lung sounds would also be key. In the cardiac patient, a high flow of oxygen, 10 to 15 liters per minute, would be required through a non-rebreather, while also for the respiratory patient through a bag valve mask. With little perfusion from the heart, what blood is being circulated for our cardiac patient needs to be well, if not over-oxygenated. Lastly, circulation would need to be checked through skin condition, color, and temperature. Both a radial and carotid pulse should be found, starting with the radial point. This area is one of the furthest on our extremities and would be a telltale sign of shunting, which can mean the patient is entering a state of shock. Although neither of these patients are in a circumstance of trauma, if any major external bleeding was present, it would need to be taken care of. Then, we as EMTs can move on to do our secondary assessment. This involves the decision to transport, an examination which can be fast for trauma or focused for medical emergencies, obtaining vital signs, asking deep medical history questions, administering interventions, and a full head-to-toe exam. With all of this being said, going through our ABCs first is critical and could answer some of our questions in the process. Even though in our situation both patients are critically ill, the respiratory patient has a lesser need for immediate transportation. Instead, quality interventions can be sustained longer to keep the lung tissue from dying. However, the cardiac patient must be immediately transported, as the only definitive care is a qualified cardiac doctor. Before we start talking about interventions though, 2 focused medical exams must be completed. With chest pain patients, unreproducible pain can be a sign of acute myocardial infarction. Therefore, palpation of the chest to see if touch triggers the pain or makes it worse is crucial. Documentation of medical history is also very important. To get a full overview, ask questions that follow the OPQRST and sample acronyms. These stand for onset, what caused the emergency; provocation, what makes the problem worse; quality, where is the pain / what do you feel; radiation, Is the problem spreading? Severity, on a scale of 1 to 10, how bad is it? Time, how long has this been occurring? Or signs and symptoms, allergies to medications, as some do not mix well and can be lethal. For example, patients on erectile dysfunction meds should not take nitroglycerin as both lower blood pressure. Past medical history, last oral intake, and events prior. Only now can a provider have all of the necessary knowledge to administer interventions to help the patient. Through this process, we must follow the 6 rights: right patient, right medication, right dose, right route, right time, and right documentation. In the cardiac situation, we can administer 324 milligrams of aspirin through an oral tablet and 0.4 milligrams of nitroglycerin sublingually in a pill or spray form. For a respiratory patient, EMTs are qualified to provide 0.25 to 0.5 milligrams of atrovent through a nebulizer and up to 10 milligrams of albuterol in 2.5 to 5 milligram doses, each given in a nebulizer over a time frame of 5 to 15 minutes. Finally, during transport, the EMT riding with the patient should continuously reassess. The biggest thing to recheck is the vital signs. Typically, these will help you monitor your administered interventions and therefore your initial and secondary assessments.